Good evening, doctors. My name is Ankur Gautam, and on the behalf of FDC and Med Talks, I welcome you all to yet another episode of Diabetes Essentials with Dr. Sanjay Kalra, Season 3. Today's topic is a very interesting topic, diabetes and the adrenals. Diabetes Essential is brought to you by your zero calorie electrolyte drink in Rizal Zero. Now, before moving forward, I would like to announce last week quiz winners. Dr. Shantanu Kumar Bhattacharya from Kolkata, Dr. Gangadhar Rath from Bhubaneswar, Dr. Prachita Srivastava from Thane, Dr. Surjit Kalsi from Noida, Dr. Bharat Praveen Mittakota from Surat, Dr. Kaval Saluja from Mumbai, Dr. Pradeep Patro from Chhatarpur, Dr. Ashutosh Das from Tamluk, Dr. Ramesh Hegde from Bangalore, Dr. Javed Ahmed from Lucknow, Dr. Praveen Thakkar from Vadodara, Dr. Nirmala Lulla from Mumbai, Dr. Anand Purande from Mumbai, Dr. Sumita Sharma from New Delhi, Dr. Ravi Bhatt from Sirsi, Dr. Sanjeev Puri from Hoshiarpur, and Dr. Satish Kumar Jain from Bangalore. Thank you, doctors, to take part in our quiz. Now, to enlighten us regarding today's topic, I would like to welcome our host, Dr. Sanjay Kalra, President, South Asian Federation of Endocrine Society, the Chairperson, Education Working Group, International Society of Endocrinology, and President, Indian Professional Association from Transgender Health. Over to you, sir.
Thank you, Ankur, and good evening, everybody. Warm welcome. Today, we'll talk about a new aspect of glucocrinology, and we'll talk about the adrenal glands. Now, the adrenal glands are a pair of very small glands. Uh, they weigh just 3 grams apiece, only 3 grams apiece, but they run the entire body. What do the adrenal glands do, and how do they impact diabetes care? Let's learn. But first, let's look at the anatomy of the adrenal glands. Like we said, they're a pair of glands, very small, just about 3 grams apiece, and they abut or they are just on top of the renal tissue, that is the kidney. That's why they are called adrenal, next to the kidney. The left adrenal gland is a bit higher. The right is lower because it's pushed down by the liver. And in each gland, we have two uh, sections or two parts. The outer part is called the adrenal cortex, and the inner part or the middle part is called the adrenal medulla. Both are totally different in terms of their embryology, in terms of their actions. The adrenal cortex is divided into three zones, starting from outside, moving inwards: GFR, glomerulosa, fasciculata, and reticularis. Zona glomerulosa, zona fasciculata, and zona reticularis. All these three zones also have different actions. The best part of evolution is that evolution has packed so much of action into these 3 grams that these glands are rightfully known as the action glands or the fight, flight, fright glands. When you are faced with any kind of stress, the adrenal glands kick in. It is the adrenal glands which help you handle the stress. How does that happen? Whenever there is stress, stress focuses on the hypothalamus. You get messages, stressful messages going to your brain, to the hypothalamus. The hypothalamus secretes a hormone known as CRH, corticotropin releasing hormone, which acts upon the pituitary gland. And this secretes in turn another hormone known as ACTH, adrenocorticotropic hormone. The hypothalamus and pituitary are linked together by a portal circulation as well. So when you have a portal circulation, like you have in the abdomen with the liver, and also between the hypothalamus and pituitary, that makes things faster because hormones are able to flow faster through a portal circulation, through a dedicated circulation. Coming back to the pituitary and to the ACTH, ACTH stimulates the adrenal cortex, which secretes cortisol. And cortisol uh, actually is a catabolic hormone because it breaks down glycogen. It, if required, breaks down protein and fat, and it helps create an immediate reserve of glucose or sugar. Of course, it decreases the immune function as well, but the immediate glucose that comes out, that helps the individual or the animal fight whatever stress there is, or fly away, flight, escape, or just become frightened. Either way, it is cortisol. that does all this. Along with that, at the same time, the medulla is also in action, and the medulla secretes the catecholamines. Catecholamines. These are adrenaline and noradrenaline. These are also the fight, flight, fright hormones, and they also work to handle stress. Coming back to this HPA, the hypothalamic pituitary adrenal axis that we are looking at, cortisol has a negative feedback on two glands, the hypothalamus directly and the pituitary directly. Whether this is endogenous cortisol or exogenous. Exogenous means we are giving corticosteroids from outside. Whatever the source of corticosteroids or cortisol, the hypothalamus and pituitary will get negative feedback. So they will reduce their production of ACTH. In disease states, this feedback mechanism doesn't work, so you might have something known as Cushing's disease, where there is extra cortisol or extra ACTH coming from the pituitary gland. That extra ACTH, excessive ACTH, leads to increased production from the adrenal. You can have what we call Cushing syndrome as well, which includes everything. The syndrome, Cushing syndrome, means that there is excessive cortisol. It can be ACTH dependent, independent. It can come from any part of the body. The primary lesion can be in the hypothalamus, the pituitary, or in the adrenal glands. But our topic today is the adrenal glands and diabetes. So let's talk about the adrenoglycemic axis. When we speak of adrenal axis, we tend to think of hypothalamo-pituitary-adrenal axis. But there are two other horizontal axes or feedback mechanisms in which the adrenal gland is involved. One is known as the renoadrenal axis. Renoadrenal. The adrenal gland secretes aldosterone and cortisol. Both come from the cortex. The kidney secretes renin and angiotensin. Both come from the kidney. And the renin angiotensin system in the kidney interacts with aldosterone mainly and partly cortisol as well. So it interacts with the kidney. The kidney interacts with the adrenal gland, and then you have together what is known as the RAAS, the renin angiotensin aldosterone system. The renoadrenal axis is a horizontal axis. It's not vertical like hypothalamo-pituitary adrenal. This horizontal axis helps to maintain fluid balance, electrolyte balance. If there is a disturbance, then we might get disease like high blood pressure or low blood pressure. The other horizontal axis is known as the adrenoglycemic axis, and we'll focus on that today. Here we'll look at the causation of diabetes or dysglycemia or hypoglycemia, the causation based on adrenal factors. We'll also talk about concomitant presentation, adrenal presentation as well as diabetic presentation. Can it occur together? And if so, what is the clinical presentation? And then briefly, we'll talk about what impact the adrenoglycemic axis has on our treatment or on our curative strategies. So let's move ahead. Our topic for today is the adrenal gland and diabetes. Now, when we look at the adrenal cortex, one of the major hormones that is secreted is cortisol. Cortisol is associated with increased glucose levels, increased weight, especially central obesity, and increased blood pressure, especially systolic blood pressure. So, all in all, increased cortisol is associated with metabolic syndrome, including dysglycemia, impaired glucose tolerance, diabetes. If high cortisol is associated with metabolic syndrome, there is research actually from the past about 10 to 15 years ago, which has shown that metabolic syndrome should be viewed as a subclinical Cushing syndrome. There is a lot of similarity between metabolic syndrome and Cushing syndrome. So this is one aspect. Also, if you have somebody with cortisol deficiency, with adrenal deficiency, it is possible that that person may present with hypoglycemia, spontaneous or induced by even low doses of insulin or oral glucose lowering drugs. So that is one important aspect of the adrenoglycemic axis. But there's another aspect, and that again is linked with the adrenal cortex, that is aldosterone. Now, aldosterone is a very important hormone. It helps maintain blood pressure. It helps maintain electrolyte balance. And what you find is that high levels of aldosterone are associated with high blood pressure and also with high levels of glucose. So hyperaldosteronism can be associated with impaired glucose tolerance. To offbeat discussions about endocrinology. So once upon a time, there was a fair, there was a meeting, and all the hormones got together, and they had an argument, a debate amongst themselves. Who is the strongest of us all? So which is the strongest hormone? Growth hormone stood up from the pituitary, and growth hormone said, "I am the strongest. Without me, you can't grow tall." The thyroid stood up, and the thyroid said, "I am one of the commonest diseases in the world. So I am the strongest. I cause the maximum disability, disease." Insulin stood up, and insulin said, "I am the strongest. I come from the beta cell, which is only 1 gram heavy. There are so many counter regulatory hormones arrayed against me. From head to toe, each and every gland creates or secretes counter regulatory hormones. I have no backup. There is insulin like growth factor 1, insulin like growth factor 2, IGF BP, but these do not influence glucose metabolism. I have no backup. I stand all alone, tall and proud. Therefore, I am the strongest. You cannot live without me." Testosterone stood up and said, "I am the strongest, I am the bravest. I do all the fights, I do all the arguments in the world. All this fighting and danga fasad that's going on across the world, this is because of me. Misplaced testosterone, so I am the strongest." Oxytocin, estrogen, they stood up and said, "We are the maternal hormones. We ensure that the human race survives, so we are the strongest," they said softly. Cortisol and adrenaline, epinephrine, norepinephrine, they stood up. They said, "We are the fight, flight, fright hormones. We are the stress hormones. We handle stress." But then aldosterone came up to the stage, and aldosterone said, "All I have to say is that once upon a time I did not exist, and all animals at that time lived in the ocean. The ocean has plenty of water. The ocean has plenty of sodium. So there was never a need to conserve sodium or water. It's only when I evolved that animal kingdom was able to come from the ocean, from aquatic environment to terrestrial environment. So if you need to survive on Earth, on a terrestrial environment, you need aldosterone. And that is why aldosterone, though it is the humblest, we hardly ever test for it, we hardly ever talk about it, it is perhaps the strongest hormone. The second concept is the renin angiotensin aldosterone system. Like we said, there is a horizontal axis known as the reno-adrenal axis. Aldosterone is an important player. Aldosterone is an adaptive hormone. It helps us survive. But if it becomes excessive, whether primary hyperaldosteronism coming from the adrenal or secondary hyperaldosteronism being secreted in response to kidney disease, either way, it becomes maladaptive and it causes high blood pressure. It can cause kidney disease. So now we actually use mineralocorticoid receptor antagonists or aldosterone antagonists, not only to control blood pressure like spironolactone, but also to manage heart failure and to prevent progression of kidney disease. Uh, the drug of choice is finrenone. So that's another aside. The adrenoglycemic axis includes the renin-angiotensin-aldosterone system. This axis, if it becomes maladaptive, can be managed by MRAs such as finrenone. There is a third hormone which comes from the adrenal cortex, and that is DHEA rather. I apologize for the mistake here. Uh, Dehydroepiandrosterone. Dehydroepiandrosterone is associated with increased blood pressure and with obesity. Increased DHES can be a comorbid or a concomitant finding in polycystic ovary syndrome. So DHEA is associated with increased blood pressure, increased weight, but there's a paradoxical response. When you give DHEA, when you supplement DHEA, you can actually get lowering of glucose, especially fasting glucose. So that's a paradoxical response. When will we use DHEA in the OPD, in the diabetes OPD? Ideally, DHEA deficiency should be documented in adrenal failure, but sometimes we use it off label as an alternative to menopause hormone therapy. DHEA is a very safe hormone which goes into the body and is broken down into both estrogen and androgen as per the body's requirement. So if you have somebody who is very asthenic, postmenopausal, or more than middle aged in men, very asthenic, complaining of loss of energy, loss of libido, it ideally one should test. But if you're not able to test, you can always give a therapeutic trial for 10 to 20 days and see what happens. We have spoken so far about the adrenal cortex, but now let's come to the adrenal medulla, which secretes adrenaline and noradrenaline. Now, these catecholamines are secreted from both the brain and the adrenal. In the adrenal, mostly we have adrenaline, noradrenaline, and the main catecholamine that comes from the brain is dopamine. All of them work together. So when you use the word adrenergic as an adjective or dopaminergic as an adjective, basically you're saying this person is a bit hyper activated. So when we say Delhi is a dopaminergic city, or Dharwad is not all that much of a dopaminergic city, though we call it Chota Mumbai. So Dharwad is a okay dopaminergic city. Dubai and Delhi are dopaminergic cities. Basically, what we are saying is they never go to sleep. They are always active. That's why when you have excessive catecholamines, then you will have high blood pressure and you will also have high glucose levels, impaired glucose tolerance. This is seen in pheochromocytoma. There is a paradoxical response here, however. Sometimes catecholamines are associated with increased weight, especially central obesity. At other times, they are associated with lean patients or with lack of obesity. So there is a paradox here. There is also a disease known as pseudo-pheochromocytoma. This pheochromocytoma itself is difficult to diagnose, not easy to pinpoint. But pseudo-pheochromocytoma means that the patient has got all the clinical features of pheo, all the clinical features of pheo, but does not have you're not able to localize the lesion, or you're not able to find the biomarkers of pheo. Yet you continue thinking it is a pheo. So that's pseudo-pheochromocytoma. The treatment would be the same way that we would manage an anxiety neurosis. Now, we have spoken about various aspects of the uh, adrenoglycemic axis, and we have seen that there are so many aspects, so many facets of this. But what is it that we see most often in the OPD? Most often, what we see is Cushing syndrome. Sometimes Cushing syndrome can be endogenous. That's not very common. More often than not, it is exogenous. Exogenous means that we have caused the Cushing syndrome by giving excess corticoids. This, unfortunately, is what we saw in the COVID pandemic as well. And that is unfortunate. As physicians, all of us should follow the concept of steroid stewardship. Stewardship means that we should use corticosteroids whenever needed, but we should use in a rational manner. It is not nice for all of us to be the brunt of jokes from people from alternative medicine, from people from across the world who say that we do not use steroids rationally. At the same time, when required, we must use. But if you are using steroids for whatever genuine indication, do be watchful for the complications, which can include central obesity, pearl striae, thick striae on the abdomen, proximal muscle weakness, acne and hirsutism, and also neurophysiological disturbances. Doses of steroids are associated with with a condition known as hypomania. Hypomania. So patient will not be manic. It will not be acute manic mania or acute psychosis, but you will get a feeling that the patient is a bit in air. Along with this, of course, diabetes can occur, impaired glucose tolerance can occur. And this is known as glucocorticoid-induced diabetes. Glucocorticoid-induced diabetes should be differentiated from type 1 and type 2 diabetes. It overlaps both in pathogenesis. There is insulin deficiency and also insulin resistance. Both are there in glucocorticoid-induced diabetes. It should also be differentiated from stress hyperglycemia, because stress will be there on both sides. In stress hyperglycemia, glucose levels will be high. but HbA1c will not be high. And the hyperglycemia will be of short duration. There will be acute stress. In glucocorticoid-induced diabetes, glucose levels will be high, HbA1c will also be high. Now, sometimes it is thought that increase in glucose is a good thing during stress. There is actually a condition known as the koala bear syndrome. Now, koala bear is a very beautiful, a very cuddly kind of an animal. In some ways, the animal is quite close to us. When we look at our fingerprints, the human fingerprint is closest to koala bear fingerprint, not to monkey or chimpanzee fingerprints. So we are closest to the koala bear. In some, we are same, but we pretend not to be the same. Koala bear sleeps for 20 hours a day. And I know many young boys and girls in India who would love to sleep for 20 hours a day if they got the opportunity. There is a difference as well. In the human being, the adrenal gland is very well developed, even though it is just 3 grams heavy. The heaviest adrenal gland per tissue, per kg body weight, is found in the monkey. And the second heaviest is found in the human being. So our adrenal glands are well evolved, monkeys and ours, and we can handle stress. The koala bear, however, has a vestigial adrenal gland. That's why it cannot handle stress. When you keep the koala bear in captivity, they don't even reproduce. They go into so much of stress and they can't handle it. So the point here is that a little bit of stress is good, but too much is bad. So if the diabetes or the hyperglycemia is in stress hyperglycemia range 140, 160 in the ICU, you do not need to treat. But if it crosses 200 milligram percent, certainly it should be treated. That's one point we would like to make here. The second point we've already mentioned, pharmacovigilance. Anyone who is on long duration or high dose of steroids, you must be pharmacovigilant and glucovigilant. Be vigilant also for infections and infestations, which will be higher in such patients. So this is how you differentiate them from type 1 and type 2 diabetes. The risk of infections and infestations, atypical infections, and fungal infections will be higher. In patients on prednisolone and methylprednisolone, there will be an evening rise of glucose. So if you just do a fasting and PP after breakfast, you might miss this. So it's a good idea to check post-lunch and pre-dinner glucose as well. If these are high, you may have to add an oral dose, any kind of an oral dose at lunchtime, which can be short-acting metformin, uh, conventional metformin, which can be acarbose or voglibose, or which might be repaglinide or glipizide. Also, when we give insulin regimens, supposing insulin is required, uh, premixed will usually not work in patients on corticosteroids. Sometimes it may. You will have to add something at lunchtime, whether an oral tablet or a rapid acting insulin. On the other hand, in patients who are not very severely hyperglycemic, NPH twice a day will do the trick in handling glucocorticoid-induced diabetes. So be aware of this disease and how you manage it differently from type 1 and type 2. Another thing we should be aware of is high blood pressure. So we mentioned the RAS system earlier, the renin, uh, angiotensin aldosterone system. There can be primary or secondary hyperaldosteronism. Primary means the adrenal gland is at fault. Secondary means the renal tissue is at fault. If blood pressure is not controlled with 3 drugs, including a diuretic, if blood pressure is not controlled with 3 drugs, or if blood pressure is associated with low potassium or muscle cramps, muscle weakness, we must investigate for aldosterone, for hyperaldosteronism. Some people say that everybody should be investigated because low potassium will be found in just 1/4 to 1/3 of all such patients. But if you feel that your patient is atypically hypertensive, something is wrong, you're not able to sort of catch hold of what it is, it's not essential hypertension, something else is there, then we have to check for hyperaldosteronism. And the simplest test is to do a renin aldosterone ratio, renin to aldosterone ratio. So we've talked of etiopathogenesis, we've talked of clinical presentation. A few tips from management. Now, mifepristone is a drug that is used for termination of pregnancy. It is also a drug that is used as per label for management of fibroid with menorrhagia. And the dose is 25 milligram once a day. Mifepristone is also approved. It is approved for management of hyperglycemia associated with Cushing syndrome. What does this mean for us? If you have a patient with menorrhagia and if the gynecologist prescribes mifepristone, be aware that it can cause hypoglycemia because it is an anti-diabetic drug, though it is approved only for use in Cushing syndrome. So in fibroid, it may be used for a long period of time. The recommended duration is 3 months. So be watchful for hypoglycemia. Ketoconazole is a drug that is used frequently in dermatology, and this too can cause hypoglycemia. It is approved for the management of Cushing syndrome if surgery is not possible. So ketoconazole may be prescribed by the endocrinologist when surgery is not possible in Cushing syndrome. Other drugs, itraconazole, fluconazole, these are used very commonly in patients with adrenal insufficiency because they have fungal disease. So both itraconazole and fluconazole are CYP, I think 4,3A agonists, and they interact with sulfonylureas and they can cause hypoglycemia. So be aware of this as well. Whenever you use an antifungal, use it carefully. So many things that we have spoken about today, and I hope it's not been too stressful for you. But let's come to our quiz question number 1. How does the adrenal gland respond to stress in relation to diabetes? When the patient or when the person is under stress, the adrenal gland hyperactivates. What does it do? Does it release more insulin? Does it produce less cortisol? Does it increase cortisol secretion because of stress? Or does it begin converting glucose to fat? So our first question, let's repeat. What does the adrenal gland do in response to stress? A, increase insulin. B, reduce cortisol. C, increase cortisol. And D, begin converting glucose to fat. Our second question, what is the role of aldosterone? We spoke about aldosterone being the strongest hormone of them all. What does it do? Does it increase insulin production? Does it regulate blood pressure and fluid balance? Or perhaps it inhibits glucagon release? Or maybe promotes glucose uptake by the cells? So let's repeat again. What does aldosterone do? A, increase insulin. B, regulate blood pressure and fluid balance, electrolyte balance. C, inhibit glucagon production. And D, promote glucose uptake by the cells. Now, this topic of adrenal and diabetes is actually a very difficult topic. And in endocrinology also, uh, you will find that this is one of the tougher aspects of diabetes to manage, one of the tougher aspects of the subject to master. Well, let's see the comments that we have. We thank everybody. A warm welcome to Dr. Anshul Singhai from Chhattisgarh and to Dr. Dharmender Dhawan as well. Anshul asks, alternative to insulin for the management of steroid-induced hyperglycemia, that will be sulfonylureas and metformin. Same, you try to manage as type 2 diabetes, but do add something at lunchtime. For short-term steroid therapy, which steroid is the safest? So all are equally okay. There is no added benefit of deflazacort. There is no added benefit of deflazacort. It depends upon what you are using for. If you are using for steroid for supplementation, then hydrocortisone is the best, like in Addison's disease. If you're using for anti-inflammatory effect, then prednisolone, methylprednisolone are better because they have relatively shorter duration of action. The synthetic ones like dexamethasone, beclomethasone will be more, patients will be more prone to side effect. Dosage will be whatever you use for a non-diabetic patient, but we have to be very clear why we are using and for how long we are using. We have to be very clear for that. If it is Addison's disease, then the treatment will continue lifelong. If it is a disease like SLE, systemic lupus erythematosus, rheumatoid arthritis, then again the dose may continue lifelong, but the dosage will be associated with ups and downs. If you have an acute exacerbation of rheumatoid arthritis, you will have to increase the dose. If patient has asthma, Then again, you may need the drug for a long period of time, and there will be ups and downs. Wherever possible, use topical therapy. Like in asthma, use inhalers. If it is a skin disease, try to use topical steroids, even though they are associated with Cushing's. If nothing else is possible, then oral steroids are given and use minimum dose. Danger signs in a diabetic patient on steroid: you have to check glucose. Remember to check the evening glucose and also keep on checking for urine ketones. The danger signs will be all the symptoms and signs, both symptoms and signs of diabetic ketoacidosis. So, patient is complaining of air hunger, patient has tachycardia, tachypnea. These are the danger signs. Good evening to Dr. Vinayak Sharma as well, and to Fatima ji, who is a student in Pakistan. Assalamu alaikum, bete, and it's good to have you with us. If we can ask Fatima, where do you study, in which college, and which year of education are you in? That would be nice. So, just sharing for Fatima ji and for everybody, we have different webinars every Sunday at 9 p.m. Indian Standard Time, which is 8:30 p.m. Pakistan time. We have a program called Diabetes Essentials. We thank Mr. Anang Basu and the team from FDC for having continued this throughout all the difficult times of COVID. Here we speak in English and we focus on doctors, on physicians. Our topics relate to different aspects of diabetes care. And like Dr. Shashi Khare says, yes, adrenal is a very difficult topic. It is really tough. Uh, every Monday and Thursday, I come on air at 7 p.m. IST, which is 6:30 p.m. PST. And here we speak in a mixture of Hindi and Urdu and English and Punjabi and Haryanvi and every other language that I can lay my hand on. And we talk about topics which are of interest to both physician community and to the general public. On the uh, 4th, that is tomorrow evening, we'll be speaking about artificial intelligence and medicine. And on the 7th, we'll be talking about microbial resistance. That is in our talk shows. We have some more questions, and Dr. Murtaza Saifi says, okay, is there any diurnal variation of cortisol? That's important. Thanks for this question. If we want to measure it, what time should we measure? Thanks, Murtaza, for this question. Now, in some species, like in dogs and animals, there is no diurnal variation. But in humans beings, we do. The cortisol is highest when we wake up. So it's a waking up hormone. It begins rising around 6 a.m. It helps us wake up and plan for the day. And it reaches its nadir, it reaches its minimum at around 4 p.m. So if you want to measure cortisol, you have to do two tests, 8 a.m. and 4 p.m. 8 a.m. and 4 p.m. And you can see the difference also. If you want to confirm any endocrine deficiency, then you have to do a stimulation test. So, like for example, here we will give ACTH. You will give an injection of ACTH. Check the cortisol before that and an hour after that, and you will see whether ACTH was able to stimulate cortisol or not. If it was not able to stimulate cortisol, cortisol is low even after giving ACTH, then certainly it is ACTH deficiency. If you want to confirm any excessive secretion, like let's say you want to confirm whether patient has got excessive cortisol or not, then you will do a suppression test. So you can do a dexamethasone suppression test. So that's how we do it. But again, to come back to your question, 8 a.m. and 4 p.m., the test has to be done both times because we do have diurnal variation. I'd like to thank everybody. It is a tough topic and the questions were also tough. And I'd like to thank once again Team FDC led by Mr. Basu for giving us this opportunity. I hope that I have been able to add value today to everyone who is logged in. And also I've been able to answer the questions appropriately. While we wait for answers and comments from Dr. Anshul and Ms. Fatima, I'd like to request Mr. Basu to take the stage.
So today's lecture actually added new dimensions to those physicians and doctors who are been loaded with patients and they may be getting some cases, maybe 1% of cases where they struggle to manage the diabetes, and that's why we have this platform where Dr. Sagra comes and gives you the extra information and difficult to treat diabetes also because the lectures has been designed in such a fashion that we cover almost every aspect of diabetes management from the window of managing it on the ground. So today's lecture was, on the series of endocrinology and diabetes, and no better doctor can be there in our platform because Dr. Sanjay Kalra is not only there to make the topic discuss with you. At the same time, if you get some diabetic patient and you're not able to manage the problem at hand, he's there every Sunday at 9 p.m. to discuss that with you, and probably he will also ask certain questions on follow up, which he can give you answers the next week as well. So we are there. Dr. Kalra is not only teaching you, at the same time he's taking care of the clinical aspect which you're getting at hand and not able to manage at your place. So that's the beauty of Dr. Kalra being there on the top for the diabetes management for last 3 years, every Sunday 9 p.m. with us. And I just thank Dr. Kalra to be there because today's topic, I'm sure, uh, many questions will be coming in follow-up sessions. I'm very sure. Maybe next 3 weeks, 4 weeks, we will getting questions of these kinds of patients when are there, and the doctors now try to manage themselves. So with this, I thank Dr. Sanjay Kalra for being with us, and he's there with us for another sessions as well. So keep flowing your questions to Dr. Kalra. Keep sharing the clinical difficult cases with them, and he will be there every Sunday to give the answers on the follow video also. With this, I sincerely thank sir for taking this session. Good night and Jai Hind, sir.
Jai Hind.